Okay, I turned on the waiting room because I don't think we were ready to let people in yet. Donna, if you would put our intro slides back up again, we talk a little bit about our Chord's background here, and we'll get started. All right. If you could go to the first slide, please. All right, maybe I'll share my screen in case we're having some technical difficulties here. All right. Welcome everyone to our Chord's Learning Health Systems seminar series. So Accords is, we actually have a brand new name for that our acronym stands for. We're the Adult and Child Center for Outcomes Research and Delivery Science. We conduct pragmatic research in real world settings to improve healthcare and outcomes by providing a multidisciplinary collaborative research environment to catalyze innovative and impactful research in health. We have several strong methodological cores and programs led by national experts. We offer consultations and team building for grant proposals in health services research and other aspects of translational research. We provide mentorship training and support for junior faculty, as well as extensive educational offerings such as this seminar series, both locally and nationally. We have a number of upcoming events, including this Wednesday. We have our Qualitative and Mixed Methods Research mini-series presented by Dr. Sheena Bull from the University of Colorado on leveraging technology to collect qualitative and mixed methods data in asynchronous and remote settings. At the end of March, and actually think this has been postponed for about a week because of spring break, we have our Community Engagement Forum on understanding and appreciating the capacities of the community and partnerships. And we can provide links to these sessions in the chat here so you can sign up. In April, we have our Learning Health Systems seminar series continuing with examples of learning health systems in Colorado, including a panel of leaders from here at UC Health, at Denver Health, and with the VA. Towards the end of April, we have our Qualitative and Mixed Methods Research Series presenting rapid data analysis by Karen Albright. And we hope you won't miss our Colorado Pragmatic Research and Health Conference, which is May 23rd, 24th, and 25th. It will be virtual, and we're hoping for an in-person component as well on disseminating, scaling, and sustaining pragmatic research. And registration is now open at coppercon.com. We also have abstracts that are due by the end of this month. Today's Learning Health Systems Models and Methods for Embedded Research seminar series will feature Dr. Gretchen Piatt, who's an associate professor from the Department of Learning Health Sciences at the University of Michigan, presenting on exploring the role of learning health systems at the University of Michigan, along with Anthony Michael Provenzano, who will be co-presenting with Dr. Piatt here today. So I will turn it over to you.
Great, thanks, Bethany. Let me see if I could share. And let me know what you see. Do you see one slide or do you see?
Looks great. One slide.
Okay, great. Thank you. So thank you. And thank you for the invitation to present today and to talk with you about the role of learning health systems at the University of Michigan and actually beyond the University of Michigan. Like Bethany said, I'm Gretchen Piatt. I'm the Vice Chair of the Department of Learning Health Sciences, and I also serve as our Associate Chair for Educational Programs. And I'm going to be joined today by Anthony Provenzano. So Anthony is a fourth-year doctoral candidate in our Health Infrastructures and Learning Systems PhD program and he's also one of my advisees. So I was happy to sort of tag team with Anthony today. So in today's seminar, basically we have three main things that we wanted to cover, and these include a discussion of the concept of a learning health system and its applicability in clinical practice. I wasn't exactly sure how much learning health systems work the group has done in the past, so I wanted to just sort of set the scene a little bit first. We'll then move on to talk about learning health systems at the University of Michigan and sort of the aspirational qualities of improved clinical practice. And then finally, we'd like to share with you some information about the health infrastructures and learning systems degree programs. And Anthony is going to be sharing a small piece of his dissertation work as an example of the type of work that our Hill students undertake. So with that, I would like to introduce you to Ms. Hall. And we know that Ms. Hall has been going to her community health clinic for about 10 years now. She just turned 51, and she and her husband live in an urban neighborhood. She's been a grandma now for about 3 years, and her daughter and grandchildren actually just moved in with her and her husband after her daughter lost her job. So in between all of these childcare duties, Ms. Hall continues her job as a postal worker, and she's also pretty active in her church. We know that Ms. Hall has diabetes. She also has hypertension, and she was recently diagnosed with chronic kidney disease. And she's been struggling with her glycemic control for some time now, which is pretty common. So she came to clinic today complaining of increased fatigue, nausea, and she noticed that her feet and ankles seemed to be swollen. So I want you to take a look at the sort of case here in the yellow box and think about what a typical treatment plan might be for Ms. Hall. And then I want you to compare and contrast it to the plan laid out here in the white box. So how do we make this jump from this very common list of symptoms and common treatment plan to this more comprehensive patient plan? You know, we go from just thinking, oh, she needs to control her blood sugar, to, oh, well, maybe we need to think about her social determinants of health. Maybe we need to think about her treatment preferences. You know, when doctor or healthcare provider is seeing her at the point of care, they're able to search the literature for nausea and fatigue and swelling as possible symptoms of decreased kidney functioning. They then go on to implement a treatment plan, communicate it to the care team and to Ms. Hall and her family. Then all of a sudden, you know, we have new data about Ms. Hall's symptoms, and that data are generated and they're stored and they're reported on. And in the process, we're learning from Ms. Hall and we're publishing in the scientific literature, sharing our evidence with colleagues and allowing them to learn from your experience to help other patients like Ms. Hall. So the big question is, you know, how do we get over to here? And in our opinion, my opinion, the answer lies really with learning health systems and the infrastructure needed to make them successful. So while the plan in the white box is largely aspirational, and I think we can all agree on that, with the right infrastructure in place, it becomes possible to achieve this. So, like I said, that infrastructural component comes from the learning health system. And in its most simplistic form, you know, I think as most of us know, a learning health system collects data to generate knowledge and then applies it to improve practice. So it's a health system in which outcomes and experience are continually improved by the cyclical nature that you see here. And it's continually improved by applying science and informatics and incentives and culture all to generate and use knowledge in the delivery of care. And we also know that learning health systems can improve value, they can reduce unjustified variation, support research, enhance workforce education, training, and performance. So the framework on the right here represents sort of some key challenges facing anyone building a learning health system or taking a learning health systems approach to the research they're doing or the practical work that they're doing. And in clinical settings, and also in community settings, for those of us who work more in the community than in the clinical practices, the learning health cycle really starts at the center of this circle here. And it begins with the generation of research questions. And these research questions tend to come from interactions between patients and clinicians and systems leaders, people who are doing research on it. And oftentimes we refer to this group as the learning community. And I'm going to come back to that concept in a minute or two. So as this cyclical process keeps on going, new knowledge is generated through learning health systems research. It's then integrated into the biomedical knowledge network. Then we think about scaling it to patients and taking into consideration the unique needs of each patient and their local system and community. So while it's great and it's all encompassing, we also know that the learning health system is very fractal, meaning that conceptually, all of these things listed around around the circles here are challenges, whatever the system's scale is. So, whether you're working in a small medical practice to an international health system, when you're doing learning health systems work, you are going to be focusing on almost all of these. And at some point, some will be challenges, some will be facilitators, but you'll be hitting on all of these elements in order to bring a learning health system to life. So it indeed is a unique and complex system of technologies. And in my opinion, I come from public health, and I tend to think that all of this technology and infrastructure and everything is needed, but at the core are people and people talking to one another, and making all of this happen. So why do we develop learning health systems? Well, we know from the evidence that they improve patient outcomes, they provide better value in healthcare, generate generalizable knowledge, and on and on. And I would say, as most of you probably know, they are becoming more and more popular. So when we dig in, so if you go back and remember that the green and blue circle, and then we hit the center of it, the center circle. So if we dig into the center of the learning health system, there are these cyclical building blocks that provide the infrastructure that's so important in propagating any type of cycle of learning. So first, if we focus down here in the green, because this is as we conceptualize learning health systems and learning health cycles at Michigan, we tend to start them down in this green arrow. So first and foremost, data must be generated from practice. It must be captured and stored and accessed and protected, and the quality of the data must be ensured, and it must be shareable and understood between settings. This is also the area of the cycle where we tend to form a learning community. And like I said, I'm going to get to that in a minute. Knowledge, going into the blue arrow, knowledge then must be generated from the data. And there are so many ways to generate knowledge. And, in clinical practice, the most common way to generate data is probably through an RCT. But there's also, I think, as most of you know, huge range of quasi-experimental study designs and different analytic methods that also generate knowledge. Other methods include artificial intelligence, machine learning, engineering approaches. And we can't forget about the qualitative work. The qualitative work also fits into this data to knowledge era. And then as we come around the circle and make our way into the red arrow, knowledge must be put into practice. And, for those of us who consider ourselves implementation scientists, we know that it's not enough to just publish in books and journals and reports. It must be put into practice. Things like clinical guidelines can be represented in standardized, machine readable and computable forms that are then used on the front line. So this is where I sort of focus on, and Anthony does as well a little bit. So if we seem a little bit biased in the knowledge to practice side of the cycle, you know why. So like I said, learning communities are hugely important in a learning health system. And in fact, they've been referred to as the cornerstone of learning health systems. So basically, we think of a learning community as a group of stakeholders who come together in a safe space, meaning, people aren't going to argue their points back and forth, and there's collegial sharing. So they gather together and they reflect and share their judgments and uncertainties about their practice and discuss ideas or experiences that need to be improved. So the thing about a learning community is that they build trust, they build capacity, they build skills, confidence, and they build agency for change. And that is one of the most important things as we are thinking about moving through that cycle. We consider a learning community a success if they remain intact throughout the whole cycle, as that agency for change stays constant. So I want to now give you sort of an example of this type of work in a more applied way. And we were contacted by Gastroenterology a few years back now, and they wanted us to help them improve colonoscopy prep. And I think most of us know that colonoscopy prep really kind of sucks. But what they were finding was that there were so many patients with inadequate bowel prep. So they formed a learning community. And this learning community, and I sort of highlighted here what part of the cycle this was in. This learning community was an interdisciplinary community, and it was made up of people from gastroenterology. It was made up of people from our department, also folks from industrial operations engineering and healthcare engineering and patient safety. And this group included physicians and nurses, but it also included, and probably almost more importantly, call center staff, patient educators, graduate students, research staff, and then patient advisors. And through their meetings and get-togethers, they were the ones to identify that inadequate bowel preparation was a big problem that needed to be fixed. So as the learning community was exploring like what the heck was going on with this bowel prep, they were able to rely on the data in the EHR. We have Epic as our EHR, and they noticed, and this is just one of the graphs that has been shown over time, but they noticed this high rate of inadequate bowel prep across Michigan Medicine. So Michigan Medicine is our health system at the University of Michigan. And This inadequate bowel prep ranged from 10 to 12% based on site and demographics. So as you could see here, anywhere in this particular graph between 10 and 19%, with the most inadequate bowel prep happening in the very elderly age group. And the learning community knew that accessing and standardizing and processing these data proved to be quite a challenge, and it was going to require multiple interventions to be put into place in order to address this problem of inadequate bowel prep. So as they circled around the learning health cycle, they ended up developing a couple different interventions. I'm going to talk about just one today in the interest of time, but the learning community developed a patient communication package. And what they did was, because patient bowel prep was identified, the learning community thought that making the instructions for the bowel prep using that as an early target would have made the most sense, because it was the one area where they were receiving the highest number of complaints from staff and patients. So, the instructions weren't clear. There were multiple different bowel prep methods that were being used, and the instructions it was an instruction sheet that had all of them listed. So it wasn't clear to people which one they should be doing. So patient communication was also prioritized. It was a low effort, high impact item that they could address. And this communication package had 3 parts. So they redesigned the patient instructions for the bowel preparation. They tailored the automated calls to alert patients to an upcoming procedure rather than calling it a more general appointment. That was something else that people seemed to be complaining about. When they got a call to remind them, they weren't clear about what appointment they were being reminded about. So they started using the word procedure. And then they tailored the patient portal messaging to alert patients to the upcoming colonoscopy appointment. So while these interventions, so to speak, don't seem very, I guess, in depth, or I don't know, they don't seem to have a lot of parts to them. They really were the right ones that were needed, because this was based on the learning community's feedback. And they were successful. I don't have their actual data slides to share, but the learning community defined success in this project by these criteria here listed on the left. And their results that were achieved was that there was establishment of buy-in from these diverse stakeholders across GI. There was multi-site involvement and alignment around a central problem of interest, inadequate bowel prep. They were able to involve engineering, and they implemented this patient communication package, which improved patient instructions for bowel prep. So, the results are not what I would say clinical researchers are used to seeing. But as we know in learning health systems and in implementation science, we have to be much more focused on the processes around these initiatives rather than the outcomes, the clinical outcomes. We already know that better bowel prep is going to lead to easier colonoscopies and identification of possible issues in the colon. So finally, I want to turn our attention to the health infrastructures and learning systems, educational degree programs that we have in our department. And I think that the experience that I described in gastroenterology is exactly why we needed to create a degree program in our department. So our motto, I guess, is lead, change, and transform health. And we offer a PhD program in health infrastructures and learning systems, and a residential and an online master's degree in health infrastructures and learning systems. So basically, what is HILS, and why is HILS unique? So HILS addresses the social and technical challenges that systems face in making continuous health improvement routine. So if gastroenterology approached us or approached a HILS student, they should be able to take what they know and help that clinical department in figuring out what's going on and how do we improve this these inadequate rates of bowel prep. In the HILS program, we have a joint emphasis on information and social science. And I think that makes us a little bit different than a typical public health or a typical informatics program. And our students design, implement, and evaluate innovative change and continuous improvement. And as of today, in 2022, we're still the first and only grad program of its kind in the United States. I think that some other universities are catching up for sure. And the reason that we went in the direction that we did is because we felt like the future of healthcare, of learning health systems, is very transdisciplinary. And just in our student cohorts, we have students with backgrounds, ones who are healthcare professionals. We have students from engineering backgrounds, from public health backgrounds, from informatics backgrounds, organizational policy and project management. So it truly is a very transdisciplinary program. And when we developed the curriculum, we were very careful to intertwine the curriculum around the learning health cycle. So you could see that in any of these arrows, and these are just some of our core courses, but in any of these arrows, we have courses that go along with each segment of the cycle. Like I said, we have a residential PhD program, we have a residential MS program, and we have an online MS program. If anyone's interested or know of anyone who's interested, we're still accepting master's applications until June 1st. So with that, I am going to turn it over to Anthony. And Anthony, I will click your slides for you. If you could just tell me when you need the next slide. And he's going to talk a little bit about some of his dissertation research.
Thank you, Gretchen, and good afternoon, everyone. I'm Anthony Provenzano, as Gretchen mentioned, a PhD candidate in my last year of the Health Infrastructures and Learning Systems program. I'll be discussing the learning health system approach used for my dissertation research with community health centers. Next slide, please, Gretchen. So in my first year of the program, I joined an academic community research partnership with the Department of Family Medicine and Michigan Primary Care Association. MPCA represents all 40 federally qualified health centers here in Michigan, and they have established the Michigan Quality Improvement Network, which represents all of the health centers, to learn and improve care through the use of data and technology. So through a partnership, we apply learning health system approach to our research engagements. One basic principle of this approach is that MQuIN network consists of 40 distinctive socio-technical systems, but collectively operates as one learning health system. So to understand health infrastructures and learning systems, through the program and in the community, we rely on the literature from multiple disciplines. As Gretchen indicated, it's very transdisciplinary in nature. So, for example, we borrow from classic infrastructure theory. One example is Thomas Hughes' 1983 study of the electrical power grids and their networks. We also borrow from computer and information sciences, where we rely on ultra-large technical systems theory. And Edwards and colleagues work on cyber infrastructures. In science and technology studies, we utilize socio-technical system frameworks and maturity models, which help us to understand this human technology interaction, and the adoption of health information technology. And then from implementation science, we borrow different frameworks and constructs to learn about healthcare setting, inner and outer context, as well as human behavior, such as CFIR, which is the Consolidated Framework for Implementation Science, and the TICD, which is often used in clinical practice around tailored implementation for chronic disease. Next slide, please, Gretchen. So my dissertation research was conducted to understand cross-sector care and data interoperability among MPCA's network of health centers. The health problem, as Gretchen discussed earlier, is sharing social determinants of health data with external partners across sectors. And we looked across behavioral health, public health, and social care. So for our methods, we developed a practice survey and interview guide using socio-technical models and integration theory to understand the health center service capacity to provide cross-sector care, and the health information technology used to exchange SDOH data electronically. So the learning cycle was used to guide the network's research initiative to discover this underlying SDOH data infrastructure. That is, the different types of data architectures, standards, and policies that were used by the different practices that emerged from the study, that we can inform practice level and network changes. Next slide, Gretchen. So these are some preliminary findings from our main results from the practice survey. And for the purpose of the presentation and interest of time, I did include all the findings. And in fact, I'm still working on the qualitative, as I'm hoping to defend for my dissertation in June. But what you see here is the percentage of health centers that have the capability to deliver and electronically connect with external service providers, presented by sector, behavioral health, public health, and social care, and by social determinants of health domain. So 34% of the health centers address safety and violence prevention, providing both domestic violence and child welfare services, where 15% of the family and home care providing housing, food, and child care services, and 20% address money and resources, providing financial, transportation, and criminal justice services. Only 9% addressed occupational support, providing both employment and educational services. So as you can see there, when it comes to data interoperability, that was focused on the service capacity in order to address those needs. But when it came to data interoperability and their ability to exchange this information electronically, there's a similar pattern where only 13% of the health centers exchange data electronically for behavioral health, about a third of the health centers for public health, and that was focused on, we looked at maternal and infant health services, and so on. You'll see the values diminish. So regarding some conclusions around cross-sector care service capacity, while Michigan's health centers have made progress in delivering behavioral health and public health, more workforce development is required to address social care needs. Food assistance, domestic violence, and transportation represented most by the health centers in terms of providing that service to their patients in Michigan. And then when you look at data interoperability and use, health centers have built the HIT capability to interoperate with behavioral health and public health sectors, yet their efforts are nearly non-existent for social care as they're beginning to build up the service capacity to address the need. So next slide, please. Thank you, Gretchen. So efforts to address around the policy implications for practice, efforts to address SDOH have helped increase healthcare service capacity to deliver cross-sector care. Data interoperability across sectors will be incremental without proper investments in service capacity building and workforce development to address SDOH in both clinical and community settings, as well as to offer financial incentives for developing provider health information technology capabilities. So to kind of circle back around, as for our partnership with MPCA and the Learning Health Cycle, we're co-hosting a meeting in June to disseminate these study findings. And in addition to this, there'll be, of course, more findings to come, but what they'll receive from that meeting, they're going to learn more about the emerging practices and partnership models that we found from the study, some facilitators to building service partnerships and clinical community linkages to connect them with community-based agencies. They're also going to be provided with HIT strategies to manage cross-sector care and to achieve data interoperability. And then we have also discovered some health center activities used at the community level to develop groups and initiatives and payment models and workflows that emerge from the data that we share with. So these findings are able, they are the data to knowledge component of the learning health cycle, and they'll see the knowledge to performance as well as future studies for academic community partnership. Thank you.
I think that's all we have for today. So I'm going to stop sharing. And I see that there are some questions in the chat. Yeah, happy to answer questions you might have, comments, all of the above.
Thank you so much for your presentation today. Really appreciate it. That was really fascinating to see your approach and your case examples. Thank you, Anthony, for sharing your dissertation information with us. That was great. So as Dr. Piatt mentioned, there are a number of questions in the chat. So we'll go through here. And if others have questions, please feel free to type them into the chat. And if you do need to go sooner than later, we hope you stick around. We have an evaluation that we would really love for you to fill out. And Madonna's going to put the link in the chat, both now and later. So we hope you stick around, but if you do need to go, we really appreciate your feedback. Okay, all right, so Russ Glasgow is asking, referring back to some of the slides earlier on around your inadequate bowel prep project, did the providers trust that data? And perhaps I can extend it to say, how did you help them trust the data to inform future work?
So that's actually a great question. Thanks, Russ. The people who were sort of championing this bowel prep project were physicians. So it became, as some of us know, like, colleague to colleague, they believed them when they were able to see the data. And I think that having a physician champion sort of take on that role of explaining the data to others is hugely important. But it seemed to me, and I wasn't involved as a member of that team that was working, but it seemed to me that their learning community, like, they were all in, and the physicians in gastroenterology similarly were all in. So
fantastic. So I just want to make sure I'm understanding and reflecting back that one of the important things in a learning health system is that the questions that you undertake are not things that you sit around and dream up that you're interested in investigating, that they're problems, real world problems that are emerging from the health systems, from the people who work within those health systems and served by those health systems.
Exactly. I mean, so many, and I think Anthony can attest to this. I mean, so many of the research questions that we focus on, they're not coming from me dreaming up what I want to do about diabetes. It's coming from people in the health system or in the community who are, saying, hey, we have this problem and we need to try to figure out how to fix it. And, I think Anthony's dissertation is a prime example. I mean, that work started out, way back 4 or 5 years ago with just us trying to figure out how do we get behavioral data into the EHR. And then it sort of grew from that. But yes, you're right on, Bethany, by saying that the questions are very pragmatic in nature.
Yeah, and
And
I was
go
I was
ahead.
just going to add to that in terms of, MPCA and their work, forming that network, the MQuIN, the Michigan Quality Improvement Network, that was their first attempt of hearing all the voices of those centers collectively in order to identify what the problems were and what they were seeing that they could address together and learn from. So it kind of, it became one of the first questions that they were trying to address around addressing the needs of social determinants of health and bringing that into the fold, and that network was able to support those efforts.
And this relates to Dr. Wagner's question and what you were just mentioning around the role of community in defining your learning health system priorities is, well, what is the patient and community role in the decision-making process about what's needed, what's developed, what's prioritized?
Mm-hmm. Yeah, I think that, for those of us who come from a public health background, we're very used to like CBPR, very used to patient-centered care. And all of that is not lost with the learning health system. And in fact, it should probably be amplified. I will say that in any learning community, the patient always has a place. Even if, like when I think about stakeholders and stakeholders making up the learning community, even if that patient may not have a lot of influence over the interventions that are happening in the health system or in the community, they have a lot of interest in the work that's being done because it's about them. So in my opinion, they always have a seat at the table. And similarly, when, for those of us who do work in the community, like most of my research is all community-based, we work very closely with different community organizations, community sort of gatekeepers as part of these learning communities so that the buy-in is there. They feel like they're an active member of the community and an active participant in helping to make the decisions.
And there's a follow-up question here, so I'm going to skip to this one and then I'll come back to some of the others. And I would even broaden it to say, how do you make your stakeholders aware of the learning health system, of the resources available, how to engage with you? And so how do you do that? How do you make people aware that you're here for them?
Well, I can speak to the community health centers and their work. So a lot of their, in healthcare in general, are working on continuous quality improvement as an effort, across these health systems. So there is some work already being done. And I think what they've done there at MPCA and other state networks is they've built on that to kind of harness a group and officially formalize it and beginning to address their needs, where before they were just collective, there weren't collective efforts to address that. And then also there's other incentives in terms of the federal government providing grant funds to the state PCAs that they can apply for funds to do just this, to bring them together into a network and begin to operate such as a learning health system would.
Yeah, I would say that a lot of the community organizations find out about learning health systems by way of the quality collaboratives that exist. Or, there's researchers at the university who are tied to our department who do community-based work. With the health system, it's a bit easier. I mean, we're a basic science department in a medical school. So people are aware, like the clinical departments are aware that we exist. They're aware of the type of work that we do. So we get questions from many clinical departments all of the time. We have an initiative called LHS-MM, which is LHS for Michigan Medicine, and basically it's if you think about a unit being consultants, they'll come to us and say, hey, we have this problem. Can you help us figure out, how to fix it? And then, we kind of go into the spiel about, well, this is the learning cycle. This is what it can do. This is how you will, how improvements can occur. But it's also a lot of, like I mentioned, so much of learning health systems is about the people. It's also a lot of us building and maintaining relationships with clinical faculty.
And so who needs to be in the system, be part of the learning health system, so that providers and communities will seek you out? Are there sort of key stakeholder roles, key leadership roles that you would advise be involved? If we were going to do something similar, who would we need to make sure was at the table?
Yeah, I mean, if I was thinking about that, so I would sort of think about it as a stakeholder engagement exercise, maybe, where, you would have your health problem of interest. And, you would want to make sure that you had people who had high levels of influence. So maybe those are like administrative people. But they may not, but those same people who have high levels of influence might not be all that interested in what you're doing. But they can make things happen. And then you have people who are sort of opposite of them that have high levels of interest, but low levels of influence. I think of those people as patients and other, people who, may work in that clinic, in that organization, but they may not be involved in the project that you're proposing to do. I think the people who have high levels of influence and high levels of interest are those key people who really make the projects run. And in the case of the bowel prep project, it was the physicians, it was the call center people, it was patients, because they had to follow the instructions, and then it was also these patient advisors. So they were the ones calling people and telling them, hey, don't forget, you're going to have to do this and do that and do this and do that, and don't stop drinking the solution until this is complete or that's complete. So those were really the people who drove it. So I would say that it's health problem specific, rather than saying, okay, all of Michigan medicine is a learning health system, because that's not the case. I think that's a pie in the sky wish that we all have, is that the leadership would just one day say, oh yes, and now we're going to be a learning health system. But instead it's more problem based, and taking learning health systems approaches to many problems.
That's a really fascinating insight there, Gretchen, around you can be a learning health system in one endeavor and one initiative and not in another, that it's something that, you know, is a cultural
Right.
approach that you bring to a particular problem,
Right.
as opposed to we as an institution are a learning health system, and this is the approach we bring to everything.
Exactly. So, you know, that is the ultimate goal, obviously, is for these academic medical centers and other medical centers too, to become learning health systems. But for the most part, with the exception of like Geisinger, Intermountain, there's really not many more that I would consider to be an actual learning health system. That said, it doesn't mean that you can't take learning health system approaches to the work that you're doing. And that's sort of what we've had to do as a department. I mean, we can't make the leadership of Michigan Medicine say, oh yes, you know, of course, now we're learning health system. So it's continuing to sort of prove the concept over and over and over again. And until someone says, okay, yeah, this is what we're doing.
And so there's a related question here. Well, what would be the bare bones resources to launch a project that brings a learning health system approach? What would I need? If I'm writing my grant, I'm bringing together my resources, you know, what do I absolutely have to have there as a bare minimum?
I would say, and this is just my opinion, you know, I would say you need a learning community. So you need to be able to assemble people who are interested and who have some influence. You need data. You need an existing data source to understand the problem, whatever problem you're interested in. And you need someone who knows how to do implementation science, so that you know how to, so there's someone to design an intervention and then implement it. That would be my opinion. I mean, I'm sure others, I don't know, Anthony, if you have any additional thoughts, and I'm sure others have other ideas.
Anthony, any other thoughts about what you would need, what you would suggest?
Well, just adding on to that, just, you know, having that learning community is essential, you know, having a shared problem of interest to be solved. Yeah, access to data. It doesn't always have to include technology. When you think about a learning health system, that's also something to keep in mind. It could be clinically focused, but, you know, to understand that problem, as Gretchen indicated, you do need some sort of data to inform and improve.
And so then the next question here, I'm sort of constructing a discussion from all these various questions. How is this funded? What's your funding source?
Yeah, so I mean, we're heavily externally funded. You know, our faculty have R01s and R18s, and there isn't, if the question was sort of getting at, is this funded with hard money? It's really not. I wish it was. If it's a clinical problem, sometimes, you know, the clinical departments will say, hey, we have X amount of funds to help this along. But for the most part, it's us partnering with these clinical departments, submitting grants, trying to get them funded, that kind of thing.
So one last question here that I think is nice to cap us off is, do you think the concept of learning communities might be different for public health focused versus healthcare health system focused LHS projects? And how do they differ?
I do think that they're different. I think that even though the learning communities who might assemble around a clinical problem in a health system, even though they may say, oh, social determinants are really important, you know, public health is really important, I'm not so sure that ends up being the case. I think that it tends to remain very clinical in nature, or health services in nature. However, in the community, your learning communities in the community, I would say are much more broad. You'll have people from health departments and from federally qualified health centers and from churches, so in addition to like providers and researchers and folks like that. So I think they're more broad. I don't know, Anthony. I think you probably have a pretty good idea of how they differ.
Yeah, I think their questions might be slightly different in terms of what they're trying to address. Certainly their
Yeah.
constituents is broader in nature. It might include social services, other key stakeholders from a local community, and determine on what aspects they're trying to address, albeit a problem with a particular disease or disease focus, or maybe a problem around trying to address a community health need. That's going to vary in terms of who participates and who's involved in that network.
Well, thank you both so much. I really appreciate your presentation and your insights. And so on behalf of Accords Education, we thank you for your everyone's participation today. And this will be archived along with the slides on our Accords Education website. So thank you, everyone, and hope to see you next time.
Yeah, thank you, everyone. It was a pleasure. It was good to see you, Bethany.
You too.
Thank you, everyone.
Okay,
Pleasure.
take care.
Bye.
Bye-bye.